Welcome back to Scissors and Scrubs. I'm Nicole.
I'm Laura.
And I don't know why I feel this way, but I feel like we haven't recorded in 3 years.
Right, but it's only been like 2 weeks.
Right.
Yeah.
It just feels like it's been forever.
That is weird.
So it's a lovely summer day here in
it's
New
so
England. Mike just got a new pizza oven, and he just cranked out some of the most fantastic pizzas I've ever had.
They were delicious.
He did like a Big Mac one with some fake meat because Laura's allergic to everything. And you can't even tell it's fake meat.
You really can't. You really can't.
It was absolutely delicious. So I'm also going to talk about my scam today because I want to make everybody aware because I can't believe I walked eyes wide open into this scam. Getting my nails done today. And I get a text from Metro Credit Union, which happens to be my credit union, which is only in New England. I might even only be in Massachusetts, telling me that somebody tried to get $800 out of my account. And I'm like, oh, and my daughter's overseas right now. So I'm like, oh, is it to her? Did she get declined? Excuse me. So then they tell me they're going to call me, and it comes in from Hawaii. That should have been my first clue. Why is Metro calling me from Hawaii? But I'm thinking, because I've got a million other things in my head now, I'm thinking, oh, they've,
branched out.
They branched out. Like they're contracting out.
Massachusetts to Hawaii.
Well, they're contracting out. So I'm a complete moron. I can't remember any passwords, any usernames, nothing. And they send me these texts, which are saying, enter your old password and username so that they can verify your account, blah, 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 blah. And the guy's like, well, it's your online banking. I'm like, I don't know what the passwords are. Well, you just need to put them in. And I'm still not getting it. No. Like, how could I not get this? I'm like, dude, call my husband because he knows the passwords. I don't know what they are. I forget them the moment I sign them. So I give him Brian's number. And Brian calls me back within minutes. He's like, yeah, that was a scam. I'm like, what? He goes, Hawaii, Nicole? Like, you didn't pick up Hawaii? I'm like, I didn't pick up Hawaii. He's like, yeah, as soon as I said to the guy, who do you work for and where are they out of? He hung up and that was the end of that. So he went to the bank, found out that it was a big fucking scam. The bank's like, we would never ask you for passwords. Of course you would. I know this. I know this. But I'm panicking because I'm like, oh, my daughter charged something and now her card's going to get shut down. Ugh. So I walked in wise, and then Laura, and being so compassionate, texts me and told me in case my son calls and says he's in jail, don't send money.
I'm just reminding you not to do that.
I know I'm a dope, but I'm not that bad.
Well, sometimes people panic.
Oh, that was bad. All right, so this week we're going to cover ECMO.
ECMO.
There's a reason we're covering it, but I don't remember why.
Because there was an article in the New Yorker about how it's redefining death, and we saw it.
Oh, Massachusetts is actually putting out a bill this year on like assisted suicide and stuff, which is very interesting because, you are prolonging life with this stuff.
In a very no kind of answer way. So,
well, and what's kind of disturbing is we've had a couple of donations, people on ECMO who are awake and consenting to their donation.
Yeah.
Because they know the moment it's turned off, they're not going to make it.
Yeah.
That would be very difficult for me.
Yeah.
I think that's a very fine line.
Yeah, that's what this article is touching on.
It's a very fine line. All right, well, take it away, Sparkles.
All right, so I'm kind of jumping back and forth here. All right, ECMO. ECMO is Extracorporeal Membrane Oxygenation. I'm not going to say that again.
That's what we're going to say, ECMO.
Yeah. In 1931, John Gibbon, who was a surgical resident in Boston.
I can't believe it was that long ago. Because I thought this was like brand new in the 90s.
He started
playing around with it.
So he cared for a woman that had a PE, a pulmonary embolism. He had no treatment for her, and he sat and he watched as she slowly died overnight.
They didn't even open them up then and get it out?
No, I don't know if there was no option.
Right.
I don't.
Right.
So Gibbon has said, quote, during that long night, the idea naturally occurred to me that if it were possible to remove continuously some of the blue blood, the non-oxygenated blood, put oxygen into that blood, and then to inject it continuously, the now red blood back into the patient's arteries, we might have saved her life. We would have bypassed the obstructing embolus and performed part of the work of the patient's heart and lungs outside of the body. By 1934, Gibbons had developed a machine that could support the circulation of a cat for 30 minutes.
Wow.
In 1952, it was finally ready for humans.
20 years later.
Gibbons used the machine to replace the heart and lungs of a college student while he operated on her heart to repair a defect. She survived, and modern open heart surgery was born.
So he mainly came up with the heart lung machine.
Yes.
More than ECMO. Because I think of them as completely separate.
I mean, they're not really, though.
Right. You're right. You're right. They aren't, but I
Yes.
think of them as separately. Okay.
So Gibbon circuit became integral in cardiac surgery. However, it directly mixed blood and oxygen, which makes the blood toxic after about an hour. There's no filter in his machine.
Oh, okay.
So in 1965, Robert Bartlett, another Boston surgical resident,
I'm just saying.
built a membrane oxygenator, which allows oxygen to be slowly diffused into the blood across a semi-permeable membrane like the alveoli in your lungs. Within 3 years, Bartlett's device was keeping animals alive for up to 4 days through ECMO circulation. In 1971, his colleagues used this setup to support a man in respiratory failure. He lived on the machine for 36 hours and became the first survivor of ECMO.
Wow. What year was that?
1971.
Oh, I wasn't even alive yet. I can't say that too much anymore.
In 1975, Bartlett and associates used their device to sustain a newborn who developed respiratory failure after birth. Within 15 years, hundreds of babies were saved using ECMO with a survival rate of 80%. This became the standard of care in pediatric hospitals. But in 1979, adult trials of ECMO found a mortality rate of 90%.
They say the babies always do better.
Yes. So it was mostly ECMO was mostly a neonatal pediatric thing. The use of ECMO on adult patients pretty much stalled from 1979, those trials, until 2008, when the H1N1 influenza emerged. Patients being placed on ECMO with H1N1 were able to be kept alive while their bodies fought the infection off. Another trial on adults was performed in 2009, and it found that ECMO helped with respiratory failure from other causes, and the number of hospitals offering ECMO increased threefold within 10 years. In 2020, COVID arrived. And ECMO was used to help bridge patients to recovery or till they could get a transplant. Studies during this time showed ventilated patients had a 60% mortality rate.
That's still high.
Ventilated patients. Yes, it was very high. Vented patients that were placed on ECMO had a 60% survival rate.
Oh, all right. Yeah.
Jeffrey Delavolpe, an intensivist in Texas, wondered if skipping intubation and going straight to ECMO would increase survival and do less damage to the lungs. Because when you intubate a patient,
traumatic.
It's damaging to lungs. He treated 52 COVID patients. 12 were placed on ECMO before being ventilated. They found the average survival rate for vented ECMO patients was 50% in this study, and it was 75% for the ECMO first patients. Wow. This study suggests patients do better on ECMO alone because they are awake, they're able to move around, they're able to have physical therapy, they're not laying there medicated.
I can't imagine
intubated.
Being awake on that.
I know.
I can't for a second imagine being awake on that.
Delavolpe envisions ICUs using ECMO instead of ventilation and sedation. Many doctors are pushing for the use of ECMO in more situations. In France, emergency responders have used ECMO to treat cardiac arrest since 2011 outside of the hospital.
How?
They have a portable ECMO machine in the ambulance. In 2014...
How are they getting the lines in?
They do it in the field.
That's bizarre.
In 2014, Dimitris Yiannopoulos from the University of Minnesota started a similar program and found that they could save half of the cardiac arrest patients by going on ECMO after CPR, as opposed to the 6% survival of patients that received CPR alone. By using ECMO in cardiac arrest patients, they have tripled the survival rate of out-of-hospital cardiac arrest. I'm going to go over real quick, what ECMO actually is, so you can, envision it.
Because, these lines and everything, I just can't imagine who's putting them in. Are doctors on these ambulances?
No, I think the,
EMTs?
I'm sure it's the paramedics, but
still.
Yeah.
I mean, these are significant lines.
Yep. All right, so putting a patient on ECMO involves inserting 1 or 2 cannulas in the patient's neck or their groins. Based on the patient's illness, the ECMO team will decide what type of ECMO to use, the number of cannulas needed, and where they will be placed. The cannulas are tubes large enough to allow blood to circulate through the external pump and oxygenator and return to the patient's circulatory system through the tubing that connects these pieces together. So it's a whole...
It's a system. And these when they say cannulas, these aren't little cannulas.
They're not like an IV. They're big.
They're about bigger than a pencil.
Oh, yeah.
They're decent size.
Like a highlighter almost. Right. There's different types of ECMO. The 2 most common ones are VA and VV ECMO. VA is veno-arterial, And that can be used for heart and lung support, while VV or venous ECMO is used for lung support only. VA can also be called cardiac support, although lungs are also supported, and VV may be called respiratory support. So you might hear those words come up. Focusing on the major organs supported in the 2 different ECMO types. The ECMO team will determine which type is necessary for a patient based on their needs. VA ECMO provides support for the patient's heart and lungs by allowing most of a patient's blood to move through the circuit without going through the patient's heart. So no blood is going through your heart.
Giving the heart a break.
This type of ECMO takes blood out of a large vein and returns it into a large artery, allowing oxygen-rich blood to circulate through the body even if the heart is too weak to pump it. Therefore, 2 cannulas must be placed in either the neck or the groins. VV ECMO provides lung support only, so the patient's heart must still function well enough to meet the body's needs. It has to be able to pump out this blood. So 2 cannulas are placed into veins in spots close to or inside the heart. With VV ECMO, the surgeon or physician performing the cannulation has an option of using a special type of cannula with 2 lumens. This allows for blood to leave and return the body in one place, creating only one entry site.
That's
instead
cool.
of 2.
I don't think I've seen that.
Yeah, I think we usually do VA. But blood from the ECMO system returns to the body before the heart, and the patient's own heart pumps the blood through the body. So your heart is still working if you are on VV ECMO. People involved in ECMO. So the physician responsible for ECMO care can be from several different disciplines. It can be an intensivist, so someone that works in the ICU. It can be an emergency physician. It can be they can work in pulmonology or cardiology, etc. This physician has special training in ECMO, patient assessment, management, and care while on ECMO.
We have an anesthesiologist who doesn't.
Right.
He's excellent.
Yes.
Excellent.
And I think he's technically an intensivist
as well.
Interventional cardiologists can place a patient on ECMO in the cardiac cath lab using peripheral cannula insertion techniques. And they can also remove them off of ECMO. Cardiothoracic surgeons may help put a patient on ECMO by surgically inserting cannulas where required. We do this, and they can do it in several settings. The OR, they can do it bedside in the ICU. They can do it in the ER. Vascular surgeons can be involved in cannula placement or removal. A perfusionist is going to be involved, and Nicole's going to talk about perfusionists later, so I won't. An ECMO coordinator is usually a registered nurse or a respiratory therapist or perfusionist who specializes in management and operation of ECMO. The coordinator will prepare the machine and tubing when the patient is placed on ECMO. And again, Nicole will get into that. ICU nurses are going to be involved in this.
When we go up to do ECMO, it's like a everybody wants to get a piece of this, and there's like 85 people outside of the room watching what you're doing.
Yeah. A registered nurse that has unique skills in caring for extremely sick patients is an ICU nurse. One of these nurses will be at the bedside providing critical care nursing to the patient. The ICU nurse may also be an ECMO specialist. And they didn't mention this, but OR nurses are involved.
Laura and I had an ECMO one night in the emergency room, and our OR is 3 floors above the emergency room. And we have to get all these carts to get to the ER. And the carts are like high. They're really tall.
They're
right?
like 9 feet tall.
I'm 5'8" and the thing's a good 2 feet above me, right? So we're running. We're running down to the ER. Now, these big doors have those metal, like little squares that come down from the door jamb.
Yeah, it's like the locking thing on the top.
Well, the cart doesn't fit past the door jamb, so we're running because somebody's half dead. Yeah. And all you hear is ba-boom as the car goes right into that metal thing. The whole ER is like, sorry, we got this. We have to maneuver it between, and it's not an easy car to maneuver. The two, and it's like 3 a.m. The two of us are like, Jesus Christ, they're gonna be dead. We get down there, they're doing chest compressions. I'm like, this is ridiculous.
Yeah, we have a shorter cut now.
Yeah. I mean, I had one night too where I was, I got food poisoning. I was violently ill.
Oh, yeah.
And they had me go upstairs to scrub one of these in the ICU, which I've never scrubbed. And the guy's literally in full cardiac arrest. They're doing chest compressions. And I look at the nurse with me and I was like, I gotta go. She's like, now? I'm like, yeah, I gotta go right now. I'm gonna puke. I'm sweating. I couldn't even think. All I was doing was moving the instruments in the pan. I didn't set anything up. I'm just moving shit and I'm sweating. I'm like, I have to get out of here. I'm gonna throw up like on the table. And she's like, right now? I'm like, call the desk. I gotta get out of here. It was not a good night. No. So I'm not a fan of ECMOs because they terrify me.
I actually like that they're quick. They're fast. You know
They
it's
are
needed.
now, but they weren't always.
Yes,
that
no,
way.
they weren't always, but now they're very
They are now,
streamlined. We do a
and
ton of them. And
like I said, that guy is part of the reason. He knows what he wants. He
Yes.
comes in. He's very direct.
Yeah.
He's very calm. There's no bullshit. The guy that used to do it before him.
oh my God, it was a
If I could
nightmare.
have punched him in the face and strangled him with the ECMO
changed it
cannulas,
every
I would've-
single
Oh, he
time.
was
It was a
an
nightmare.
idiot. I couldn't stand him.
Yeah.
I'm sorry. Go ahead. I digress.
Anyway, so why do we use it? Like what
Why do we use
what
ECMO,
conditions?
Laura? Please
So
tell
some
me.
heart conditions in which ECMO may be used include complications from a heart transplant, like you need to rest that heart.
Yeah.
Heart attack, heart muscle disease or cardiomyopathy, a heart that can't pump enough blood because you might be in cardiogenic shock.
Right. And if you don't know what cardiomyopathy is, it's what Barbara Hershey had in Beaches.
Oh, wow.
Yeah.
Pull
She was
that out of
dying
nowhere.
from cardiomyopathy.
hypothermia,
Oh.
sepsis,
Warm the blood, I guess,
Yeah.
right?
sepsis, and swelling and irritation of the heart muscle or myocarditis. So it's like an inflammation in your heart. Some lung conditions in which ECMO may also be used is ARDS, or acute respiratory distress syndrome, a blood clot that blocks and stops the flow to the artery in the lung, which is a pulmonary embolism, which is how this all got invented. COVID-19, fetus breathing in waste products in the womb, which is called meconium aspiration. And that is almost always why we're doing it for babies. Hantavirus, pulmonary syndrome.
Oh, hantavirus.
Yeah.
If you don't know about it, we covered it in one of our Thanksgiving episodes.
Yes.
I think it's like first year out, we covered it.
Yeah. Pulmonary hypertension, which is high blood pressure in the lungs.
That shit's no joke. That'll kill you. Pulmonary hypertension.
Yep. Congenital diaphragmatic hernia, influenza, pneumonia, respiratory failure, severe allergic reaction, or anaphylaxis is the word for that, and trauma.
Yeah.
Risks of going on ECMO include bleeding. You have to heparinize the blood so there aren't clots that form. So bleeding is a risk. Blood clots are also a risk because you have to be heparinized enough to not form blood clots. You can get a clotting disorder called coagulopathy, infection, loss of blood supply in the hands, feet, or legs, called limb ischemia.
I've seen it a lot with the
Yes.
legs.
Because if you go in through the groin and you're drawing the blood out from there, the blood's never getting down
To
into
the
that leg.
Right.
So there are cannulas that they can place to put in the leg, but sometimes it's so emergent
Right.
and the patient's doing so unwell, they can't put it in right away.
They're going to sacrifice the leg to keep the light.
So sometimes you lose that leg. Seizures and stroke. And ECMO does not treat or cure any disease.
Mm-mm.
It's
just supporting you.
It
while
is
you
a
have it.
support. It is a short-term help when the body can't provide the tissues with enough oxygen and blood flow. It is support only.
Yeah,
it is
you can't
not a
live on
treatment.
ECMO forever.
It is not a treatment.
And when you do an ECMO for an adult versus a kid, like when we're training people, I always joke, I'm like, okay, when a PD ECMO comes
Yes.
in, you know about 3 months ahead of time that this child's going to be born on September 13th and he's going to have meconium aspiration. And you go up and it's 4 hours and the doctors come in and everything's very precise. And it has to be. These babies are so
Oh my God, those little
small.
teeny vessels.
And it's 1,000,000 degrees and like it's so precise.
Yeah.
And you get an adult ECMO and they're like, get down to the ER. And we're crashing carts into the wall and the patient's already in
It's
cardiac
a
arrest.
completely different ECMO.
Our ER is so overpacked with
Oh my
people.
God, it's crazy.
I brought a trainee down there to to do ECMO, and this guy, he's on a stretcher eating chocolate cake, watching us. He's like, "This is better than Grey's Anatomy," and I'm looking at the nurse. I'm like, "Can somebody put him somewhere else? Because this is a HIPAA violation, right? Like he shouldn't be watching us put this guy on ECMO. This is a little."
I had a guy on the stretcher in the
upsetting.
hallway and his wife sitting on the end of the stretcher. They're just both staring
Watching.
at us. The guy's having CPR. We're doing the ECMO. I'm like, this is
They're like, "This is great."
something else.
He's eating his cake. I'm like, "Wait, this is inappropriate."
Yeah. This ECMO seems wonderful, right? Like you give your heart a rest, your lungs a rest, you feel better, you can survive. Seems wonderful. But the technology is far ahead of the ethics.
Correct.
About 10 years
As
ago.
is everything.
Yes. About 10 years ago, a teenager with cystic fibrosis was admitted to a New England hospital after his previous lung transplant started to fail. He was put on ECMO while he waited for new lungs. 2 months later, while he's on ECMO,
He was on ECMO for 2 months.
doctors found that he had developed an incurable cancer.
Was it because of the ECMO?
I don't know why.
All right.
Maybe the med. I don't know why. But now he's stuck
On ECMO.
because he's on ECMO, and that's the only reason he's alive.
Right.
But now he has incurable cancer, so
And-
he can't get a transplant. So he had to live in the ICU because he's on ECMO, and you have to be on the ICU when you're on ECMO. But he's awake. He's talking. He's moving. He's getting up. He's texting friends. He's doing homework. He's participating in life. So now an end of life conversation has to be had with caregivers, family, and the patient who's awake.
And fine. Excluding he's on ECMO.
Right. So it's delivering a death sentence. In this case, the care team and the family, I'm assuming the patient, decided that they would not actively withdraw the ECMO, but choose not to replace the oxygenator when it began to wear out. As it failed, the teenager gradually lost consciousness and died.
Fuck.
So they were saying, like some doctors in this article saying, like, we have a fear of letting people die, which we've discussed in other shows. But ECMO was invented to be a bridge. It is not a treatment. It is not a cure. Whether it is to allow the heart and lungs to rest so the body can fight off an infection, or it gives someone time until they receive a transplant, it is a bridge only. It is not meant as a treatment. By placing people on ECMO that have nothing to be bridged to, we are blurring ethical lines. These people can live on this ECMO.
I'm going to come back to this. I'm going to cover perfusion and respiratory therapists because I got some stuff to say.
Yeah.
And I just feel like I don't want to get into this
debate
with you. And then, oh, by the way, let's talk about this.
Yeah. So I got that information from the New Yorker and Mayo Clinic, and I believe that. Oh, and the it's actually the ECMO organization. There's like an organization of ECMO.
So I'm gonna cover the people who run these machines. I wish these are respiratory therapists I had known about, but I wish I had known about a perfusionist. Perfusionists are very little known people in the operating room. We talk about them in Hurricane Katrina episode, and somebody actually wrote in to say thank you for talking about us. It's a fantastic career that nobody knows about. So we're going to talk about them real quick, and then we'll go back to ethical issues because this could get heated, Laura. All right. So
I think we're probably on the same side.
I know we're on
this.
the same sides. It's my husband. All right. So the definition of perfusion describes with fluids such as blood and lymph tissues. Lymph. It says lymph as, but I know that's not what I wrote. They go through the tissue, like your blood. It's going through. And a perfusionist is a professional that operates machinery when this process requires assistance like heart surgery. So they are taking the place of your circulatory system while you are either having heart surgery or you are on ECMO. They operate equipment that externally and temporarily replaces or assists the heart and lungs. They keep the person alive during heart surgery when the heart needs to stop, and they also run the ECMO machines. They are not doctors. They usually work in the OR, but can be seen running machines like ECMO in the ICU. And in our facility, they also run the Cell Saver, which is it's a suction machine. So if somebody's actively bleeding, it sucks up their own blood, it runs them through the machine, it cleans it, and then they're able to get their own blood back. The education is they usually have a bachelor's degree in science, like biology or health sciences. This is a new degree out there that I had not heard of. So a couple of people I know whose children went to nursing school and either didn't like it or kind of washed out of nursing school and now taking health sciences.
Oh, yeah.
And that's like, you can work in the cath lab, you can do this, you can do that. So it's kind of a cool degree, but I don't know what you'd do with it unless you specialize.
Slightly vague.
Right.
Until you specialize in something.
You'd have to specialize in something. So if anybody has this degree, feel free to write us and tell me what the hell it is. Okay. You need certification from an accredited perfusion technology program, or the pizza that's doing it to me. Extracorporeal technology program. You need certification from the American Board of Cardiovascular Perfusion. It all takes usually 4 to 6 years, and they need to do state continuing education. The responsibilities of a perfusionist
are a lot.
They're on call all the time. They're there all the time, and they're in all aspects. They're in the ER, they're in the ICU, they're running the liver, they're running the heart, they're all over the place. So while operating the machine, they are responsible for, making sure the machine runs correctly, ensuring the patient remains stable while hooked up to the machine. They order all the equipment, everything they need for their machine they're in charge of. They monitor vitals. They monitor the normal blood flow, the body temp, and other vital signs. And they also try to prevent blood clots and bleeding with heparin. A lot of their direction is coming from the surgeon in the room. So if they're running the bypass machine, the surgeon's telling them, turn yellow, turn red, cardioplegia, put this in, put that in. They are running all of the labs. When they go on, anesthesia literally is like, we're out, and they take a break until it's their turn to come off the machine. They're in the room and they're monitoring. They ain't doing shit because
everything's running through the machine.
Is doing everything. They provide medications to the machine. They run the labs. They are used for cardiac bypass, heart and lung transplants. And our facility, we do liver veno bypass, and they'll come in and run that. It's a much smaller machine, and they'll do it to help the bleeding on the livers, because livers can be extremely bloody procedures. In some facilities, they run the aortic balloon pump and other ventricular assisted devices, which can also be kind of a ethical thing. Some of these devices, you have aortic balloon pumps, you have ventricular assisted devices that these people's hearts are done. And these machines, they're put on these machines and they can't live without them, and they're waiting on heart transplants. We really do step in a lot. People are like, oh, it's God's will, but we're taking place. So we're going to get into all this, okay? So that came from Medical News Today. In other facilities, respiratory therapists run them. Our facility, it is strictly perfusionists.
No, up in the ICU, those people are respiratory therapists.
Because I know I see them around, but I didn't know I thought perfusion was running them on their
No, they'll go up when we put them on ECMO, but the person doing the machine
is the respiratory therapist. Okay, so when I was an EMT, one of my partners was going to become a respiratory therapist. Not a career I would enjoy because I don't like sputum.
I don't like suctioning tricks.
Yes, and they're knee deep in sputum. So a respiratory therapist, also an RT, is trained to he has skills to assess, diagnose, and treat patients who have difficulty breathing. They work with people of all ages in conjunction with the doctors and nurses to come up with treatment plans aimed to help restore as much natural breathing as possible. They are working with COPD, with cystic fibrosis, with all kinds of breathing issues. They work in hospitals, clinics, doctor's office, critical care units, ERs, and inpatient homes. So they can come to you like a PT can come to you. Education, at the minimum, they can get an associate's degree, and many will go on to get their bachelor's degree. You also need to complete an accredited course along with supervised training and clinical practical experience. Requirements vary from state to state. Licensure is required everywhere but Alaska.
That's
random. Their responsibilities: they meet and examine patients who have pulmonary diseases, disorders, or complications. They conduct, perform, and analyze diagnostic and function tests to assess lung capacity and capability. So if you ever go to the hospital, they give you that little incentive spirometer. The RT's coming in to see how big those breaths are that you're taking, because if you don't get them, you get atelectasis and you have a problem. They work with doctors and nurses to create treatment plans. They treat patients with, it's aerosol meds and chest PT, but it's nebulizers. They're going to give you nebulizers. They evaluate treatments. They give nebulizers. They do charting. They operate the vents and the machines in the units. For us, when our patients come down from the ICUs, usually a respiratory therapist is accompanying them. They work with team members to discharge, come up with treatment plans for discharge. They train patients how to use their own equipment. I didn't have the salary for perfusionists. They make really good money.
They make really good money.
Respiratory therapists, it's about $70,000 a year, but it depends on if you've advanced your degrees or not.
My friend Frank is a respiratory therapist.
I think for what they do, their education is not what you would expect, because they do a lot.
They do a ton.
They do a lot. They're monitoring, like, the PEEP and this. And I'm like, I have no idea what they're talking about. And I've got a nursing degree, and this guy's got a 2-year associate's degree, and he's running the machines. Like, they are hard workers. They're all over the hospital. They're crucial to patient care, especially for people who have major lung issues. They're going to help you breathe until another plan comes up. All right. We're getting back to it. So my husband and I go back on this, back and forth. He is very Catholic. I am a practicing Catholic as well. I believe in my faith, but I have wiggle room. He does not. He is black and white. So I told you Massachusetts is coming up with this bill for assisted suicides, which I believe in. All right. And we went to Mass, and they sent out a whole thing on why Catholics should be against this and this and that. And I said, look, I have a glioblastoma. I have ALS. I have Huntington's. I ain't living that out to the bitter end. I'll tell you that now. I'm going to Vermont or Oregon, who has it now, and I'm getting myself done. And he's like, that's ridiculous. You know, it's God's will. I'm like, really? Because somebody's going to try to put me on a vent. Somebody's going to try to put me on stuff.
That's the part I don't understand. And usually I go to church as well. And usually when they start talking about a political thing, I leave because I'm like, I'm not
They're not
here for
aligned.
this.
Yeah.
I'm not with church and state, two separate things. Like I am but I just feel like you can't say that when you're also saying, put me on this machine, put me on this and keep me alive.
Because that's not God's will.
Because what's God's will then? Because if God's, if we're saying this with air quotes, like if God's saying, okay, your heart's done.
Right, but now I
can put a balloon in. Yeah. That's keeping you. So why is that God's will? But saying, okay, I'm done now.
Right.
You gave me. I have this disease. I'm going to die. I'm suffering. I'm done now.
Right.
Why isn't that like it?
And
just
so
doesn't make
these people
sense.
who are on ECMO who are wide awake, how is this any different?
So they're saying they're like these people are living, getting up and doing physical therapy, and they are. Yes, they're alive and have blood pressures and have a heart rate. If you took them off that machine, they are dead.
Right.
Their heart and lungs are dead.
But
we're keeping them alive and
you
walking.
could almost say it's suicide, though, when you say we're turning this off.
Right. So then it gets to that sticky point. What do you do? At least the balloon pumps and the VADs, you can go home. You wear a little bag. You can go out.
Right.
You can actually.
You can live life.
You can,
and you can be on them for
years. You
years.
can go on vacation. You can be on them for years. And you can these people. They
the
take
hospital.
up an ICU bed.
Yeah.
Which
I know that sounds cold, but it's not. Yeah.
Fine. If it's not, and you're just going to live in that ICU for 2 years on an ECMO machine with no chance of coming off.
For me, the hard part is now the organ bank comes in, and they want these organs because they know the patient's going to pass.
Mm-hmm.
And you guys are like, okay, here we go. We're just going to turn the machines off and wait till they pass. I have a hard time with it. I'd rather see them pass in the ICU. Like, we're doing it now because you want these organs? Like, where are these lines?
I mean, I think they were coming off of it anyways. I don't think they go talk to them unless they said,
I have a hard time
Wednesday.
shutting it off on somebody who's a walkie-talkie.
Yes, but that's what ECMO is.
I
They're
know.
technically only alive because of that machine.
I totally agree with you.
Right.
But how do you do that? Like, usually when you do this, they're out of they're gored. Like, they're not talking to you. They're not texting their friends. Like, you're like, okay, love you, bye. And they shut the machines off and you're done. I have a hard time with that.
Yeah.
I have a hard time with that, you know.
But
I understand it.
you can't keep on it forever. And then if you do that, at least someone else gets a good organ.
But we're getting into
it's a very gray area.
areas with a lot of this stuff.
Yeah.
A lot of this stuff.
It's a very gray area.
And like you said, like, okay, if it's God's will, then we shouldn't be putting a feeding tube in. We shouldn't be putting a
if
trach
you can
in.
no longer eat because your brain isn't functioning,
then we're not putting a feeding tube in.
Then that's saying you're not supposed to be eating because your brain isn't functioning. So I just don't understand where the line is for this stuff.
And if it's God's will, we turn the machines off. That's it. There's no machines.
Or you don't even put them on.
Right.
Like if you have a heart attack and a dead on the street,
that's it. God's will.
Isn't that God's will? Like that's what I don't understand about it. And I find it very
and I think for medical professionals it's difficult because I see a lot. I think it's unfinished business with family members where they're like, they had something they wanted to say or they did wrong by that person. So they're like, do everything to keep them alive. And that's not right either. Yeah. You know, so we could go on and on.
There's very gray lines.
Very gray lines. Yeah. Are we going to read our email today? We got an email from the girl. Do you want to read that now?
Do we have it? Oh, it's on the phone.
You want me to read
print it? Oh, I don't care. I thought he was printing it.
I thought he was too, but we got an email today from a young lady who it was a cute story, and she sent us a picture of her when she was little.
I already posted it on social media.
You want to read it? You can go ahead.
Hi, ladies. After listening to the most recent episode, I thought how I very much related to baseball accidents. I'm 25 years old now, but when I was 6, I played on a Little League team. I was the youngest kid. I was 6 in first grade, and the other kids were 7 to 10 in second and third grades. I had to be on the team as I ruled too old for t-ball, despite my skill set not being anywhere near the other kids. In the middle of the season, during a game, I took a baseball directly to my face, resulting in a broken nose.
Ouch.
That completely changed my confidence with sports, and I was too afraid to participate anymore, and I felt not good enough for the sport as the entire time before breaking my nose, too. I had not once hit any pitches, and once I broke my nose, I was afraid of being hit again as well. Before I had broken my nose, it wasn't required for us to wear helmets.
That shocks me. They're
I know.
little kids.
And this wasn't long ago.
No.
Just baseball caps, which is crazy to think about. Now, after listening to the episode, considering we were all children under 10 years old, only after I had broken my nose, it was locally enforced to wear helmets, and up to your parents' discretion if the helmets had to have the cages in front. I like to think of the butterfly effect, though, as since that happened to me and I decided sports weren't for me, I delved deep into my creative side. I am pursuing art as my career. I went to art school and got my BFA in illustration and I'm a children's illustrator. My Instagram for my art is at Amelia with an A .melberg.arts. We'll put that on our page. I also had a septoplasty in 2021 when I was 22 to correct my deviated septum.
Did you wait long enough?
from the break I got at 6 years old. As growing up with the deviated septum, I realized how much it affected my breathing, especially during sleep. I'd snore and have interrupted sleep, which affected my mental health and productivity. Since having the deviated septum fixed, I can breathe better and sleep well, so all is good. Here is a picture of me with my freshly broken nose the day after it happened. Stay safe and have a good rest of the summer, Amelia.
Okay, Amelia, here's my question. How did you find us if you're an arts major?
I know.
That's my question.
Oh,
I love that you're listening,
Yeah.
But please, by all means, tell us how you heard about us.
That's a good question.
And tell all your arts friends about us. One of my girlfriend's daughters just had her deviated septum fixed, and right afterwards she was miserable. Like, she's like, oh my God. I said, I know, it'll get better. She'll be happy she did it. So like after they took all the packing out, she's like, are you kidding me? You guys have been breathing like this your whole lives.
This is how normal.
She's like, this is how I should have been breathing my whole life. And they're like, yeah. I said, I told you she's going to be happy she did it,
It's worth the pain.
So this isn't exactly like a huge summer episode, but I mean, you guys are slacking. You're not giving us episodes.
But
so
also,
this is what we're coming up
ECMO
with.
is used a lot in drownings.
Yes, it is.
So,
which we were almost going to cover, but we've already covered drownings.
We've spoken about drownings, but ECMO is used a lot because obviously your lungs are damaged.
Yes.
You're usually
and they
dead for a little while. They bring you back with CPR and they place you on ECMO to hopefully give your lungs time.
You said hypothermia too. So if you're out in the cold, they're going to warm you up because you're not dead till you're warm and dead.
Right. My aunt's brother-in-law was a lobster fisherman.
That's right. That's right.
He fell over into the boat. I don't know if he had a heart attack or what, and they found him. They brought him to the hospital, put him on ECMO. He did unfortunately die, but if you drown or anything, they will, if they can get you back, you will probably be put on ECMO.
So that's our ECMO episode. Tell us what you think. Go ahead and feel free to write and say hi. I know it's summertime and everybody's on vacations. Laura's going away without me and it's very upsetting. That's right. Very upsetting. I will be in lovely scenic Swampscott while she's away. So feel free to write to me at least because she'll be having fun in the Azores.
I won't read it
without me. All right. Enjoy your summer. Stay safe. Don't go on ECMO.
No.
Like, subscribe, rate, and review the Scissors and Scrubs podcast on whatever podcast app you listen to us on. Follow us on Twitter, Facebook, and Instagram at Scissors and Scrubs. And email us any of your stories or thoughts to scissorsandscrubs@gmail.com.